Good evening, everybody. It's 8 o'clock and Happy New Year to one and all, and welcome to the first episode of Marvelous Medicine of 2022. I have great pleasure in welcoming Dr. Muralidhar Rajagopalan and Dr. N. Anand, who very kindly consented to do this program at an extremely short notice. Normally, I give my speakers and moderators a few weeks notice, but due to some unforeseen circumstances, the program had to be changed. So I'm extremely thankful for Murli for being my knight in shining armor. Quick introduction for Dr. Nat Anand, who's going to moderate the session. He's a consultant dermatologist at Kaveri Hospital, Chennai, and he runs Skin Research Center and RV Diagnostic Center in Chennai with his wife. He did his MBBS diploma in dermatology and MD dermatology at JIPMER Pondicherry. He also did his DNB in dermatology and venereology. He's a visiting faculty in several medical colleges in Chennai. His areas of interest are dermatopathology, photodermatology, and management of psoriasis, vitiligo, and autoimmune blistering disorders. Anand is an avid runner and he's completed several full and half marathons. Like he said before, he's a trustee of Dream Runners and is the head of Bessie Runners, avidly promoting and guiding new joinees to take up long distance running. Welcome, Anand, and would you please make the introductions for Murli?
Thank you, Vidya. Thank you. First, I'm not with any hospital, including Kaveri. I just admit cases in Chennai, Meenakshi. I'm on my own, full-time on my own. I've become much more relaxed in the last few years. Thank you for the introduction. Now, I don't think any of you needs introduction to Murli. He's one of the most well-known, if not the most well-known dermatologist across India and in many parts of the world. In a way, when I joined in 1985, when I joined MBBS, Murli was in the double batch. Don't know whether he remembers ragging me for some time. And subsequently, sometime in 1988, when we used to have a posting in dermatology those days during MBBS. So I kind of fell in love with dermatology and then did a little bit of background and realized that a person called Muralidhar Rajagopalan threw away his medicine to become a dermatologist par excellence. And there's the only word I can use. He, in fact, in medicine I heard him tell me once that people should do a little bit of medicine before doing dermatology, and it's of immense help. And I tell you, his work, it shows in his work because he's so good in his internal medicine. And that's what helps him enormously in dermatology. Of course, there's not any dermatologist in India who doesn't know Murli. Everybody knows him. More importantly, he occupies several chairs, and very proud to say that he got recently selected to be, I think recently, right, in the Atopic Dermatitis Board of International Society. And proud to say he's the first Indian to be in this position. I don't think there's any other Indian in this. He's the first Indian to be in that position. And that's the kind of work I always think of him as an exceptional and knowledgeable guy. It's very difficult to, he has set a benchmark. Once upon a time, Tony Cozier remarked that, this bowler, what's our fast bowler, West Indian fast bowler, Michael Holding, was called the Rolls Royce of fast bowling. Murli is the Rolls Royce of dermatology. He set the benchmark very, very high, and it's for all of us to catch up. So I'm very sure he will bridge the gap for you medical general people to understand where we stand in psoriasis today. I would not add anything on it. I'm just waiting to hear Murli talk about it. Over to you, Murli.
Thank you very much, Dr. Vidya, and thank you very much, Anand. Vidya, especially, thank you for calling me a knight in shining armor. Never been called that in my life. Came on the most unlikely situation. Thank you, but thank you for having me here, Vidya. Been following your programs, and I think this is a good forum you all are having, and grateful to be here. I know Anand for many years, but Anand, I don't remember ragging you, and ragging is a good way of becoming good friends. Looks like I have forgotten that. So it's good fun. And I am, however, grateful to you for your kind words. The reason why I chose today's because Vidya gave me a free hand to choose some topic which I wanted. And the reason why I chose this topic on psoriasis is because I work for the International Psoriasis Council. I represent India there. I've been there now for the past 15 years. So now I'm heading their division of education and started their master classes and fellowship programs for the IPC. The atopic dermatitis thing came up later, and it's only because of basic interest in immunology, which puts me there. Having said that, if you would give me permission, I would like to share my screen with you. Now, in today's discussion, I'm probably going to spend about 45 minutes. That's how much time Vidya told me on psoriasis. We thought we label it as psoriasis more than skin deep. I mean, when we were, Anand will also remember when we were all doing our MD, no one used to talk about psoriasis as being a systemic disease, but it's time we recognize that psoriasis is a systemic disease, and rather it's a marker of several problems and issues that could be happening internally. I do remember that when I joined Apollo, I work at Apollo hospitals now, and I head the department there. So when I joined, they used to call me for these cardiothoracic surgeons, used to call me to screen patients prior to surgery, and they had a package. And in this package, patients were admitted for just 7 days for the entire bypass. And invariably, I would find in at least 20 to 30% of patients, I'm talking about the 90s. Many of the slides I'm going to show you belong to the 2000 late, post 2000. But in the 90s itself, we could see that there were a lot of them who were psoriatics. And it did strike me, and I wanted Apollo to start a registry. There are dreams, and this still remains a dream, and we will end with that. But the point here I'm making is that this is an extremely complex subject. This picture, I love photography. This is something which I put up in my CV slide. I really love photography. If there's anything I love more than dermatology, is photography. And this is from Florence, and it's an intricate church over there. The amount of detail that goes into each and every little aspect of this is no match to what happens in psoriasis. My conflict of interest statement is important since I am on the international advisory boards of all the major multinationals, because I belong to the IPC. Even here, I'm speaking on behalf of the IPC, who are in psoriasis research and primary drug development. I've spoken for most of the companies on newer concepts in drug usage, and for the IPC and SPIN. SPIN is the newer formulation where we realized that psoriasis and atopic dermatitis were two sides of the same coin. So instead of calling it a psoriasis interest network, it was called as systemic inflammation in psoriasis and called as SPIN. This talk is not influenced by these associations. However, what am I going to do in this talk? I'm going to look at the implications of psoriasis on the general health and other internal organs. I'm going to basically talk about what a non-dermatologist should know. Dermatologists like Anand are excellent clinicians and physicians, and they know whatever I'm going to be speaking, but the audience we are addressing today is primarily non-dermatologic audience. And we are going to talk about the comorbid conditions that we see in psoriasis, which affect practically every organ. And therefore, one needs to be alert and not just dismiss psoriasis as just some damn skin disease. It's a multi-system inflammatory disorder. It has significant comorbidities. Notable comorbidities are cardiometabolic. Now, when we talk about cardiometabolic comorbidities, we are talking about fairly serious conditions here. Now, my mentor for psoriasis is a gentleman by the name of Alan Mentor. And he's at the University Medical Center Psoriasis Clinic in Dallas, in Texas. He was the man who got me into psoriasis in the late 90s. And I'm very grateful to him. This is a slide that he lent me, pictures of the patients that he sees. And we had done a little program, and he's in fact the founder of the International Psoriasis Council. We were trying to address this question of, can we target specific therapies to specific psoriatic phenotypes or genotypes, that is the pharmacogenomics. This was part of that lecture. So this is a slide from his collection. I'm not going to be boring you with the details of treatment. I will, however, be talking to you about all these various types of psoriasis, which all of you know and you've seen. And there are many phases of psoriasis. You can even get lesions on the soles. You can get lesions which sometimes people mistake as ringworm or fungal infections. You have lesions on the scalp. You have lesions on the fingertips, which is very difficult to treat. And nowadays it's being mistaken for the hand eczema that occurs frequently because of excessive paranoid use of sanitizers due to the COVID situation. And you have psoriatic arthritis. Psoriasis and psoriatic arthritis go hand in hand, whether it is dactylitis or enthesitis. Look at this over here in the Achilles tendon. You can see the fullness. It's very easy to make out that there is going to be involvement of the joints once you see a fullness over here. If you really cannot make it out, if you do an ultrasound or a normal appearing Achilles tendon in a psoriatic patient, you will be able to make it out. The reason why we are talking about this is we do not want our patients to have problems like this. I've had several patients who've had a destruction of the distal interphalangeal joints, and that makes their quality of life miserable, and it has a serious socioeconomic burden. Dermatologists invariably see these patients first because the joint involvement may succeed the onset of psoriasis by even 5 to 10 years. And even patients may not realize that they had a patch on the scalp or in the gluteal region. And many times, even rheumatologists don't look at the connection. We have seen this happening. The key message there is a statement that fools rush in where angels dare to tread. I was the fool who started using biologics and psoriasis in India way back in 2003. At that time, I was condemned as being somebody who is getting rid of a good drug like methotrexate. But now today we know that not using a biologic in a patient with moderate to severe psoriasis can produce deformities of the joints, decrease the quality of life, make a patient prone to heart attacks, strokes, and early death, all of which are statistically validated. Not to talk about the psychiatric problems, depressions, suicides that happen. You will be very surprised to know that next to cancer, the highest incidence of suicide for a medical condition is psoriasis. This was an interesting paper by Rapp. And the quality of life for a psoriatic patient is miserable, and no good doctor should allow this to happen to his patient. When you look at the pathophysiology, this is a very complicated cartoon, so I'm not going to sit and go through every little bit. But we have probably identified a putative antigen, and we know today that it is probably an autoimmune disease. It's what we call as a type 1 autoimmune disease. And through tumor necrosis factor, it stimulates the myeloid dendritic cells, which in turn invites a cascade of Th and Th17 and Th22 cells, which produce cytokines like IL-22 and IL-17, which impact the skin, producing keratinocyte proliferation, resistance to infections. Chemokines get released and polymorphonucleus cells intervene. And you have Th17 cells which come in, and there is a synergistic pro-inflammatory effect. Now, based upon which cytokine you are targeting, you have specific drugs, and the list is very broad. We are not going to talk about these drugs today. So rest assured, in the next, I have another 30 slides to show you. I won't be talking about these drugs. I only brought this to tell you that, you know, we need to be familiar with TNF-alpha, interleukin-17 and interleukin-23, which are the most important cytokines in psoriasis today. And we'll see how that makes a difference to the general system itself. The comorbidities in psoriasis are strongly associated with disease duration and severity. Psoriatic arthritis, non-alcoholic fatty liver disease. In fact, a patient of psoriasis who's not even received methotrexate, most probably, especially if he's obese, would already have NASH. So it's important for us to evaluate the liver in a much better manner and not rely on hepatotoxic drugs in patients with psoriasis. The metabolic syndrome is very common. Psychiatric morbidity I just spoke about increased risk of depression and suicide. Inflammatory bowel disease, especially Crohn's disease, is very common, and cardiovascular and cardiometabolic disease. Interestingly, if you look at registries, 32% of psoriasis patients had at least one comorbidity, 10% had at least two, and another 8% had more than 3 comorbid conditions. Now, this is phenomenally important because it means that if a dermatologist is just going to dismiss a psoriasis patient with coal tar and methotrexate, he's not going to be looking at what is happening inside, and the patient may end up for a bypass surgery or end up with a stroke. So we need to be aware of this, and that's the whole purpose of this discussion we are having today. So we call this as the psoriatic march, where obesity, psoriasis, smoking, and alcohol dependence have an interplay. They're all associated, produce systemic inflammation. And we have heard in one of the previous lectures and discourses in this marvelous medicine program on insulin resistance. Please remember that inflammation and psoriasis, which contributes to systemic inflammation, produces insulin resistance. I'll just diverge for a moment over here. The insulin resistance can be documented in almost 60 to 70% of psoriasis patients. And if you treat a patient of psoriasis with infliximab, which is a TNF-alpha blocker, within 2 hours, the insulin resistance comes down. It's as effective as that, but we do not advocate infliximab for treating diabetes. Maybe sometime in the future, people will find a common drug to treat both diabetes and psoriasis. Insulin resistance is a direct harbinger of endothelial dysfunction, atherosclerosis, and myocardial infarction. So this is what happens in cardiometabolic disease. Now, this is the psoriatic march. We spoke about obesity. We spoke about, we are going to talk a little more about the metabolism in psoriatic patients, and cardiovascular diseases I touched upon, but you're going to talk more in detail. I touched upon diabetes and hypertension, dyslipidemia, and smoking. They all contribute once again to cardiovascular disease. So there is a vicious loop over here in our psoriatic patients. And this is all the more so in patients who have developed psoriatic arthritis. So if you look at this, there are shared inflammatory mediators which provide the link between psoriasis and common comorbid conditions. So there are inflammatory mediators which are produced in various tissues which contribute to the system of systemic burden of inflammation. So whether it is psoriasis, neurological disorders, obesity, hypertension, diabetes, or arthritis, there is an autoinflammatory loop. And that is why we find that as time passes, the more we neglect psoriasis patients from an internist's point of view, every dermatologist should be an internist. And if you neglect that, then you are going to pick up more and more comorbid conditions, or your patient is going to leave you because he'll probably end up with a stroke or a cardiac problem. And after that, psoriasis is forgotten completely. So this is what actually happens to psoriasis patients. So picture I took about 2 weeks ago, and the lion's share of psoriasis is cardiovascular risk. Now, there is what we call as MACE events, that is major adverse cardiovascular events. Now, this happens in psoriatic arthritis patients and even chronic psoriatic patients. But psoriatic arthritis appears significantly associated with subclinical atherosclerosis. There is endothelial dysfunction. The standard cardiovascular risk factors contribute to the increased risk of MACE. OGD reported that the risk of developing MACE is higher in patients with psoriatic arthritis who were not using even the standard DMARDs. Forget about biologicals, but even the standard DMARDs, if they were not using it, the cardiovascular risk was much higher. So irrespective of the classical cardiovascular risk factors, the systemic inflammation, that's systemic, not systematic, the systemic inflammation of psoriatic arthritis plays an important role in increasing cardiovascular diseases. So even if there is no risk factor, even if a patient does not have a metabolic syndrome, even if a patient is not a smoker or an alcoholic or an ethanolic, whatever, I have got to be politically correct here. And we find that they have increased risk of cardiovascular diseases, and that's been proven. Now, what is the evidence that a psoriatic plaque is equivalent to an atherosclerotic plaque? This is something really fabulous, which my internist friends over there will understand. There are several cytokines or chemokines involved in psoriatic arthritis. By interacting with specific platelet receptors, they cause intracellular calcium mobilization, nucleotide secretion, and platelet activation. So this is the synergism between inflammation and atherothrombosis. Mino et al. Evaluated platelet aggregability in 114 psoriatic arthritis patients. He looked at this with a tool which is called as the maximal light transmittance, that is the max-A%. The max-A% values of psoriatic arthritis patients who achieved the minimal disease activity during treatment with the TNF blocker were comparable to controls, and they were significantly lower than those of individuals with active disease. What does the sentence mean? This means that the platelet aggregation came down once you gave a TNF alpha blocker. So the risk of cardiovascular disease and stroke came down when you used a biological like a TNF alpha blocker. I promised you I won't talk about the method of using biologicals, but this is important here to understand how the use of a drug for psoriasis is going to impact the heart and impact the longevity of the patient. Now, this is another fantastic cartoon which I would really like to share with you. On the left side of your screen, you see a psoriatic plaque. And since there is so much inflammation happening there, we told you about interleukin 12 and 23. Interleukin 12 stimulates the Th1 pathway, and interleukin 23 stimulates the Th17 pathway. And both of them impact the skin to produce keratinocyte activation, proliferation, and intralesion angiogenesis through TNF alpha, interleukin 17, interleukin 23, 22, and the downregulation of the T regulatory cells. Now look at the right side of the screen. If you look at the right side of the screen, what do we find? These cytokines are absolutely similar. Same types of interleukins, same pathways, same cytokines, same downregulation, same plaque growth, and due to the Th17 effect, there is plaque instability and rupture, which can lead a thrombus away from a blood vessel somewhere, and probably it gets lodged in the brain and the patient presents with stroke. So psoriasis and atherosclerosis have similar underlying, why similar? I would say absolutely identical underlying immunologic mechanisms. And this was discovered by dermatologists in 2018. I think dermatologists have a lot to be proud about, but they should work more in cohesion with internists. But there is a tendency to shy away from working with internists, and there is a big tendency towards working only on cosmetology or cosmetic dermatology. Not that it's bad, it's good money, but I think in the interests of science, dermatologists need to work closely with internists. Now here I've just listed all the cytokines. You don't need to bother about this, but we spoke about the various types of comorbid conditions like obesity, hypertension, what is happening in the blood vessels, the liver, arthritis. We spoke about the autoinflammatory loop, and we spoke about skin inflammation. You know, all these cytokines are shared in all these areas. So this is what we just wanted to show, that psoriasis overlaps everything. And this is a very interesting diagram. Way back in 2009 in hepatology, it was discussed the prevalence of NASH in psoriasis patients versus the controls. Look at the controls who didn't have psoriasis and look at patients with psoriasis. You can see the incidence of NASH. And second, if you look at the disease severity, if the psoriasis activity and severity index, which means the extent of psoriasis is less, then it was much lesser. But if the psoriasis was more extensive, the incidence of NASH was much higher, which meant that these patients are usually in traditional Indian, I would say 98% of Indian dermatologists rely upon methotrexate, but they use methotrexate for severe psoriasis, but we do not evaluate these patients for NASH. And if they have NASH, they are going to end up with hepatotoxicity, which could be permanent. There is an increased prevalence of non-cardiovascular comorbidities like arthritis. I mentioned Crohn's disease. I will once again take an aside and mention something more about Crohn's disease here. It's important for us to understand that psoriatic patients may have underlying inflammatory bowel disease, because I've been hammering at the fact that biologicals do help us to control comorbid conditions. But here the choice of the biological also makes a difference, because in Crohn's disease, a biological like a TNF-alpha blocker, which is called etanercept, is going to make it worse, whereas an IL-17 blocker is going to make it better. In fact, using a TNF-alpha blocker like etanercept may unmask Crohn's disease in some psoriasis patients. There's a question from Ravi Shankar. Yes, the controls were matched for obesity, Dr. Ravi. I can send you the paper. I'll be answering the questions wherever possible to make it more interesting. There were a lot of other comorbidities like anxiety and depression, GERD, pain because of the joints, and also the psoriasis patients also complain of pain in the skin, and sleep disorders and insomnia. And I think we have endocrinologists over here. We have Ravi Shankar here. He will tell you that if there's a sleep disorder and you don't get your adequate amount of REM sleep, then you are going to end up with a metabolic problem. You're going to probably end up with a dyslipidemia, a cardiovascular risk factor, or probably end up with truncal obesity like I have. Psoriasis and the eye, one of the hats that I wear is that I work with Shankar Nethralaya, and I teach at Shankar Nethralaya. I teach at their Uvia clinic. I also work at their cornea clinic. And it's interesting because we are seeing a lot of cutaneous complications of various skin diseases in the eye. We will talk about psoriasis over here. There could be direct cutaneous effects like the eyelid involvement and blepharitis, and immune-mediated conditions like uveitis. Now, there was an investigation in Singapore. The eye complications are common in Asians, and they should be elicited always during history taking. Unfortunately, we find that most dermatologists do not ask the patient about the eye. This is just a picture of how bad the joints can become in a psoriasis patient. And if you look at the radiology of the joints, radiologically, there is complete destruction of the joints. This is the whittling that you see over here. And this is irreversible. And there is some degree of ankylosis also happening at the same time. Dr. Soma Balan has asked me a question. I will just come to that. The Moll-and-Wright classification, there are several classifications of joint involvement. This is more for dermatologists, but it's more important to understand that we are very worried about the distal interphalangeal joint disease, though it is not so common. It's the asymmetric oligoarthritis, which is very common in psoriasis. But if the DIP joints are involved with so many people wanting to use their hands, it becomes very difficult. And the health-related quality of life suffers. They may even lose their jobs. So what investigations will be useful? Simple tests like the ESR, the C-reactive protein, the rheumatoid factor. Second-line tests, if there is joint involvement, like HLA-B27, hyperuricemia. All these are simple investigations, but I think we are not going to go much in detail. We're going to talk about something very simple. This is a very, very simple, straightforward picture of a hibiscus. And I'm not going to talk about herbal treatment with hibiscus oil, by the way, but I'm going to come to a very vitally important question. What is the evidence that comorbidities are linked to psoriasis? Have we assumed too much from epidemiology? Now, this is partly what Dr. Ravi Shankar asked. The comorbidities of psoriasis, this is where it's going to become a little toxic, but fortunately, it's only about 5 to 6 slides. So please bear with me. I will take a minute extra to explain this. I'm very proud to say that this particular paper was by one Sudarshana Sundararajan and Mohana Priya Arumugam, both Indians based out of India. And they explored the links by the network approach. Now let's see what is a network approach. Now this is an integrated system biology approach, which is utilized to decipher the molecular alliance of psoriasis with its comorbidities. There is an unbiased integrative network medicine methodology, which is adopted for the investigation of a diseasome. I will show you what is a diseasome for biological processes and pathways of 5 most common psoriasis-associated comorbidities. That is what these authors did. And they found that there was a significant overlap between genes acting in a similar direction in psoriasis and its comorbidities. This is what they found. They also found that the biological processes involved in the inflammatory response and its cell signaling formed a common basis between psoriasis and its associated comorbidities. We've seen a bit of this, and I showed you the shared cytokines between psoriasis and various comorbid conditions. So network medicine is a branch of systems biology. This provides a systematic platform to investigate the molecular intricacy of a disease, which aids the identification of new molecular associations amongst apparently diverse clinical manifestations. In 2003, if I was to go and stand up on the stage and say that if your patient of psoriasis comes, look out for an impending stroke, you would call me a madman. Many people did anyway, and probably still do. But this is what network medicine does, because a so-called diverse clinical manifestation can be linked. I still remember that when I was in JIPMER doing internal medicine, Anand, you mentioned this, I chucked internal medicine because I found that there was absolutely no attempt towards integrating lines of thought in so-called diverse clinical manifestations. Well, things have changed today, and today we are linking diverse clinical manifestations. And then to see the commonality of the genetic expression, you can do meta-analysis, but meta-analysis, that too in psoriasis patients with so many different factors, sometimes is a bit flawed. Now, this is a beautiful Venn diagram which shows the number of overlapping genes between psoriasis and its comorbidities. Look at this blue one here, psoriasis, 507 genes. This entire amoeba-like thing is actually the psoriasis picture. It overlaps with arthritis. It overlaps over here. Over here, it overlaps completely with diseases like bowel diseases. It overlaps with atopics. It overlaps with obesity. And myocardial infarction genes are also shared over here between psoriasis, arthritis, and cardiac involvement. So we have seen the pathways being the same. We have seen the genetic sharing between psoriasis and various comorbidities. And this is what makes things interesting and gives you a very compelling argument that we are not just, talking off the hat. We are talking about something that really does exist, but is probably under-recognized as of now in the wider community. But there are a group of doctors who have looked at it in great detail. The inflammatory skin march occurs even in atopic dermatitis. Anand was very kind enough to credit me with that position in ISAD. Yes, I am there in ISAD, and I have always been interested in pediatric dermatology. Both atopic dermatitis and psoriasis are frequently comorbid with cardiovascular disease, metabolic syndrome, and autoimmune diseases, what we call as the march of psoriasis, the inflammatory skin march, or the psoriatic march. So, in fact, there is one condition which is called as SEMA, PS, and the last three words of eczema, PSCMA. So that is an overlap between psoriasis and eczema, which we do see in some of our patients. Depending upon which gene is active at which stage in the disease, patients may switch from one to the other. This has implications in therapy. I will talk to you about that if you are interested. Now, I told you I will show you what is a diseasome. I'm sure you'll be regretting why I told you that when you see this picture. A diseasome associates, it's basically a proteomic concept. When people tell me, why do you talk about biologics? I tell them, look, biologics are going to be passé in another 2 years. You need to get into proteomics now. Now, this violet nodes shows the proteins in psoriasis. You can see it's there all over. The red nodes you see are the common proteins shared between MI, that is myocardial infarction, and psoriasis. And the dark blue nodes are the indirect interactions. So even through proteomics, we have proved that MI, cardiovascular risk events, cardiovascular stroke events are all shared with psoriasis. And the psoriasis diseasome is a much larger spectrum. We really don't know what else is there in clusters like this, for example, or clusters like this, or clusters like this. We have not yet looked at all that because we haven't really gone into that much detail in investigating our psoriasis patients. And one of those things is malignancy. We don't know which cluster is going to predict malignancy. Now, this is another very interesting and easy to understand. Now, when you look at proteomics, you just want to ask me a simple question. Is there a sharing of proteins between psoriasis and comorbid conditions? Simple answer is yes. If you look at the molecular comorbidity index, what you call as the MCI, the total then over here, there is once.
Murli, you're breaking up.
Yeah, I know.
We've lost audio. Sorry.
Yeah. Okay. Yeah. So this is OMS. Then there is just 1 second because I have a problem in my head. So as far as MCI is concerned, you can see over here whether it is arthritis, whether it is MI, obesity, diabetes, or even atopic dermatitis. Everything is shared with psoriasis. So this is the molecular comorbidity index. Now there is an overlap of identified biological pathways in the psoriasis disease zone. Once again, if you look at atopic dermatitis, see the big overlap. Type 2 diabetes mellitus, look at the overlap. Myocardial infarction, look at the overlap. Obesity, look at the overlap. Arthritis, look at the overlap. Now, if you look at the proteins which are downgraded, even the proteins which are downgraded are similar between psoriasis and atopic dermatitis, diabetes, infarctions, obesity, and rheumatoid arthritis. I don't think we need any more convincing to understand that there is a common pathway and there is something common to all this that is happening in the body. So that is where you come into metabolomics. Now, in this looks at the metabolism of the body. You're going further down. You've looked at genes, you've looked at the cytokines, you've looked at the clinical associations, and then you go into seeing what is wrong metabolic. Now, as far as the metabolism is concerned, there is a plasma level of amino acids like threonine, leucine, phenylalanine, and tryptophan. They were increased in psoriasis, indicating a dysfunctional amino acid metabolism. The level of the amino acid metabolism directly reflects the state of the liver function, the liver cell metabolism. There is therefore abnormal lipid metabolism. Arachidonic acid is increased with the subsequent prostaglandin and thromboxane rise. So blood tends to clot. There is increased power. This is very interesting, which we have not talked of till now. There are increased plasma levels of uric acid in psoriasis. We used to dismiss it in many of our patients, but the problem is that this actually is a biomarker for kidney damage in patients with psoriasis. So it's not such an easy disease which you can forget about it and throw away. And these are not from some cock and bull journals. This is the European Review for Medical and Pharmacological Sciences, very highly regarded. So these are all different. So it gives you a completely different perspective in psoriasis vulgaris research. We spoke about TNF-alpha blockers. It can reduce cardiovascular disease risk. Besides the control of inflammation, TNF blockers, they downregulate even fibrinolytic as well as hemostatic parameters. They normalize platelet hyperreactivity, reducing the cardiovascular risk. Now, this is the involvement of another set of proteins I spoke to you about, the Th17 axis and the IL-23 cytokines. Their link in psoriasis and cardiometabolic disease. I'll just go through this to summarize what's happening. There is local inflammation in the tissue in the skin. There's a crosstalk with the adipose tissue, even with the gums, endothelium, and pancreas. And there are patients with obesity who are much worse, and they end up with NASH. The metabolic syndrome contributes further. The abnormal cholesterol metabolism is once again linked to insulin resistance, type 2 diabetes, dyslipidemia. All of this contributes to vascular inflammation, hypertension, atherosclerosis. All this contributes to cardiovascular diseases, the thrombi, stroke, transient ischemic attacks. Everything is done by one single problem, and that is psoriasis. So that's why I brought this all into one picture for you. I found this to be extremely useful because I think every physician should know this and not take psoriasis very lightly. So I'm coming to the end of my discussion with you. This is one of the usual sunsets. I was lucky to get a good orange ball over there. Last two slides, what have we learned about other comorbids? There is a lot we can keep talking about. I can talk to you for a week about this particular topic because I've spent 25 years working on this. We expect the same beneficial effect on other chronic inflammatory disease as well. The improvement in inflammatory bowel disease and arthropathy prevention with biologics is well known. I also told you about how the choice of the biologic is very important. You choose a drug like etanercept, the Crohn's disease gets worse. None of the benefits will accrue to the patient without lifestyle modification. We spoke about obesity, we spoke about NASH, we spoke about the fact that these patients end up with a high CRP. Lifestyle modification is an evolutionary mandate if the human species has to survive. And if not for the appearance of a skin sign like psoriasis, we would never realize the need to connect comorbidity and lifestyle medication. I feel, to end what I'm discussing this with you, that this is an evolutionary gift to man. We should not look upon psoriasis with fear. We should be happy that we are sitting and discussing this because this is an evolutionary gift. As we keep evolving, we get diseases. The diseases teach us something. We've learned something over here. None of my patients goes away without at least a half-an-hour lecture on lifestyle modification. Unless and until lifestyle modification is done, your biologics are not going to work, nor are the comorbids going to go away. In fact, they're going to kill the patient. In conclusion, and I would like to thank you for bearing with me. I did have a little break there because, you know, sometimes my brain gets thrown out. So I am late by a minute. It's a multi-system inflammatory disease. The comorbid conditions are varied, but cardiometabolic disease is major and usually ignored by all doctors, especially dermatologists. It's time that we change our outlook towards psoriasis patients. We can modify the systemic complications by treating psoriasis adequately. Most of them can be modified. We need a registry for psoriasis. And I have tried talking to the dermatologist's body several times. Doesn't work. But I can talk to this group over here because this group has taken time off to listen to something. It's a mixed audience and you are ready to listen to something which is not your field exactly every day. But the point here is that even we can start a registry for psoriasis. All that we need to do is to make people understand that once you start treating patients with psoriasis the way they should be treated, we can improve the overall health-related quality of life of human beings. It's a joke whenever you get married to a dermatologist. It's a very derisive joke that's made, saying that don't worry, along with the husband, you'll also get a lot of psoriasis patients, so you can never cure them. And with all these psoriasis patients, you will have a nice, happy life. That's a very, very sick statement, which I have heard several times. In fact, when I buzzed off from internal medicine, my professor called me and told me, why do you want to give a good dowry to your daughter? That's what happened to me. Psoriasis is not a dowry you give your daughter. It's high time you understand that psoriasis is a problem. And psoriasis is linked to entire internal medicine. And a person who wants to know internal medicine needs to understand psoriasis. And you treat psoriasis well, you're going to do very well. Thank you extremely, Dr. Vidya. Thank you very much, Dr. Radhakrishna. You've all been my wonderful friends. You put up with this lecture, but I think time has come to close. Thank you for the very, very kind invitation, and I'll be happy to take on any questions if there are. I will stop sharing my screen. Thank you.
Thank you, Murli, for finishing on time. Over to you, Anand, for your comments and any questions, and then we'll take all the comments and questions from the audience.
Yeah, thanks, Murli. From a dermatology perspective, it's wonderful to listen to Murli because, you know, as he already said, we are like tuned into psoriasis as a multi-system inflammatory disease and, you know, where we are heading for. And sometimes I see one of the figures where he showed about interleukin 70 and the dendritic cell. And I was wondering what happens to a non-dermatologist who looks at this slide and thinks, what are dermatologists doing? Well, dermatology is a lot of immunology today. And this is what we've been having from 1980, sometime around 1980s, this immunology concept of dermatology. And it's just wonderful to hear Murli go through a lot of things. Of course, a lot of new things which I learned too, new terms about, what is that, Mabonomics, something like that. New terms which sometimes helps understand a disease. As he said, it needs a lot of interaction with the internist to go. I just give an example. I had a 24-year-old psoriatic patient recently. A 24-year-old, you don't expect him to have any problems. His triglycerides were 480. His cholesterol was 280. His insulin level was sky high. And he was not obese. He was just a normal looking guy. It was a shock to the family that, all these markers were very, very high. So as Murli said, there's a lot in psoriasis than what goes on the surface of the skin. And yes, I personally do have psoriasis myself, and my mother had psoriasis. What interesting thing is, when I started running a marathon, my psoriasis disappeared, kind of completely. So that goes, I may be lean, but my triglycerides were high. Now it's normal. So there is a strong link in all these genetic patterns, as you already explained. Thanks. I think I will leave, since it's more for the non-dermatologist. I'll allow the other people to ask questions to Murli.
So Murli, do you want to take the comments and questions on the chat first?
Yeah, I can do that. I would first like to really thank everybody. A lot of wonderful people have written nice things. I'm extremely grateful. Thank you very much for putting that out there. And Vidya, thank you again. Ravi Shankar's question, hepatology paper 2009, were the controls matched for obesity? Yes, they were. Then there's a question from Dr. Suma Balan. Pediatric psoriasis is an extremely neglected area. What do you think about the necessity for rheumatologists and dermatologists working together? Dr. Suma, there are two parts over here. You see, my mandate was not to talk about pediatric psoriasis today. And I do agree completely with you that it is a very neglected area. And we need to do a lot more. Even in fact, most of the trials on most of the new drugs are not used in pediatric patients, or not given in pediatric patients. But that is more because of the technicality and the process by which a drug trial is being done. But as far as the behavior of pediatric psoriasis is concerned, it is not grossly different from what happens to an adult patient. But yes, I take your point that it is relatively neglected and we need to do more. What we have a rheumatology and dermatology clinic. Rheuma Derma clinics are there. In fact, I have conducted masterclasses of Rheuma Derma interfaces, and we do work together. Yes, in fact, it is very important that we work together, because many times we find that the rheumatologists may suspect psoriatic arthritis, but they need a dermatologist to confirm it for them. So that's as far as this thing. And I'm just one second. Yes, Ravi Shankar. Yes, Ravi Shankar, you have gone through the Kaiser Permanent database. The Kaiser Permanent database is maintained by an extremely good friend of mine, Dr. Jashin Wu. There are very many other CWATs in psoriasis. I had to confine myself primarily to the cardiometabolic complications and issues. But we have, Jashin Wu and myself, we've written a paper on this also. And yes, we have written a lot about this. And it is there in the database, and we are updating the database regularly. Then there is, there's one question, which is a direct question, which is about scalp psoriasis. I won't take any names or anything over here. which suggests that, as far as scalp psoriasis is concerned, just because it is a small patch, please do not neglect it. Having scalp psoriasis is one of the markers that one might develop arthropathy. There is a higher association of systemic comorbidities with scalp psoriasis, gluteal cleft psoriasis, and nail psoriasis. So it should be treated. And there is, someone has said that as a cardiologist, I will remind myself about psoriasis when I see my MI patients. That's nice to hear. Should statins be used prophylactically? That's a wonderful question from Dr. Purnima. I think when we talk about this over here, we're not talking about using it in psoriasis patients, but whether you should use it prophylactically to prevent the dyslipidemia, which is eventually going to occur. I'm actually happy you asked that question, Dr. Purnima, because as of now, the current project in both the Mayo and in the Texas Dallas Center, which I projected the first two slides, is they are looking at the different biomarkers to try and translate what we know from the genetics of psoriasis and the immunology of psoriasis to see whether you can preempt some of the problems that patients are going to need. There are a lot of pros and cons regarding the usage of statins, even without psoriasis, but by and large, the advantages far outweigh the disadvantages. So I wouldn't be surprised if somebody tells you that maybe 2 years down the line, we come out with a recommendation. And if I am still in the IPC, I may be part of that. Now, there's one question from Dr. Pratibha. In psoriatic patients with hypertriglyceridemia and raised HbA1c, hypothyroidism, what should be the base of treatment in otherwise non-comorbid and normal body structure? You see, the thing is, when there is, if the patient is, now let me take it as, you will have to break this down. Mere presence of dyslipidemia, it is not mandatory for you to start the patient on a biologic. But dyslipidemia is usually associated with the fatty liver. It is also usually associated with problems with liver enzymes. So you should be a little careful about using probable hepatotoxic drugs like acitretin or methotrexate. So that's something we should be careful about. Now, when you look and you see that there could probably be joint involvement also in such patients, what we need to understand is that the conventional drugs for psoriasis do not prevent ankylosis of the joints. And they worsen the osteoporosis that occurs around the joints. So that is a situation where at the earliest sign of joint involvement, you need to start a patient on a biologic. But for the reason of cost and economics, sometimes it becomes difficult. In fact, I would say that if a patient has hypertriglyceridemia, one should follow what Dr. Anand said. I mean, I told you that when we counsel our patients of psoriasis, we insist on fitness. If Anand runs a marathon, he gets rid of the hypertriglyceridemia and he also gets the psoriasis under control. Exercise brings down the severity of inflammation in the body. So lifestyle modification is very, very important. So Dr. Vidya, I think I have finished the question in the chat box.
So Ravi has his hand up. What do you want to say, Ravi?
Oh, no, I was going to ask another question. Murli had started his talk by putting those slides from his collaborator in Dallas about, phenotypic, genotypic correlations, as well as ultimate treatment, decisions based on the genes involved. So is there anything, more on that, or do all these genes feed into these common pathways, starting with TNF activation?
Thank you, Ravi. Yes, this I showed you the diseasome, I showed you the proteome, I also showed you the genetic, overlaps and the correlation. What we need to know now is that what would be the best possible or the minimum possible tests which are available in the blood to help you to look for these correlations or treat proactively. And that work is going on right now. I did make a very brief mention of it. That work is going on. The work going on in psoriasis today is to look for good biomarkers which can be done in one sample of blood and which can tell you how the life course is going to be over the next 10 years.
Can I also ask another question? I mean, you talked about the relationship with inflammatory bowel disease and type 2 diabetes. What about type 1 diabetes, which is a, I mean, some people claim that it's an inflammatory disease and not truly an endocrine disease. I mean, I have issues with that, but particularly type 1 diabetes. What are the overlaps between psoriasis and type 1 diabetes?
Frankly, not found an overlap as of yet.
No, okay.
As of yet, we have not yet found an overlap.
Murli, if I add,
Yes.
See, one of the problem with genetics in psoriasis is to call psoriasis a single disease itself is wrong.
Exactly.
It's that, there's so many poly. I just give you illustrate an example. I had a patient in 1996 who first came to me when he was 20 years old. He had a single nail psoriasis. And I told him this is psoriasis. He was shocked, surprised. 6 months later, he had multiple nail psoriasis. Those days, the only treatment was to inject intralesionally into the nails. And this guy consented and we did inject him. Fortunately, I say fortunately, because there's no certainty that he's going to get cured by intralesional injection. He got cured. 2006, he comes to me with psoriasis of the palms and the soles, right? And this is a different type of psoriasis. This time, he's diabetic. He has got triglyceridemia and the cholesterol. So you have to change your lifestyle. So he started playing shuttle and everything instead. In 2009, he came with arthritis and scalp psoriasis. And he brought his daughter along who had different type of psoriasis. You see that phenotypically, there is so much of variation that you cannot pinpoint a particular gene and say, this is the gene which is causing this type of psoriasis. So that's why it's far too early to start a very, very specific targeted treatment. Right now, we have wonderful biologics which work commonly for, as Murli said, for the inflammatory bowel disease as well as the psoriasis. But we cannot predict where this patient is going to be linked to one particular comorbidity or multiple comorbidities. It's very difficult. It's phenotypically different type of conditions and genotypically also different. Right now, we are finding each day we are finding a new gene for psoriasis.
I appreciate what you said, that there are so many coming up and the story is not yet over. The simple long and short of it is that the story is not yet over. And it is only now that these newer tools of network analysis has started. And once we complete that, we will know what are the genes that are really important. May I take 2 questions that have come up over here, Dr. Vidya?
Go right ahead. Before that, if Dr. Elizabeth wanted to say something, Dr. Elizabeth Parameshwar.
I'm afraid no, I had not put any question up. No, I had not.
Okay. Go ahead, we take the questions on the chat.
Hello, can I ask you a question?
Go right ahead.
Dr. Muralidhar, it was an excellent talk on, I'm a nephrologist and I see patients with psoriasis getting IgA nephropathy. It's being recorded. You mentioned about uric acid, because IgA again has a high uric acid, it indicates. And at present, it said the psoriasis lesion is more than 3%, but 20% of them will get renal disease. And you extensively covered the cardiac problems. I thought the renal problems are also equally common. And recently they have reported C3 glomerulopathy, which involves the alternate pathway of complements in psoriasis. So I would like to know from you how exactly this is happening. the drugs is a direct inflammatory reaction or immunological reaction?
Yeah. Dr. Muthu Jayaraman, I'm sorry, I did not talk too much about every organ. For example, I did not talk about the lung. In fact, interstitial lung disease is very common in psoriasis. And, you know, but it's because I had to stick to that 45 minutes. And in that 45 minutes, I lost 1 minute because I had a little seizure. Yeah, I had a seizure. What's the big deal? Everybody knows I have seizures. When I talk, sometimes I go into an absence. But when it comes to the renal issues, we are aware about the renal issues. We are aware about increased incidence of IgA nephropathy in psoriasis patients. And we do, in my patients, I do look at the urine sediment carefully. I don't dismiss it. I look at the renal functions properly in every one of my patients, because even the conventional drugs are going to have a bearing to play on the kidneys. And as far as the mechanism, pathomechanism is concerned, it is purely immunological. C3 and C3C is very easily documented in psoriasis and activated in psoriasis, and the whole complement cascade can bear down in psoriasis patients. Should I take a question, Dr. Vidya?
Yes, please, go right ahead.
Yeah, there's one of an association of vaccination and expression of psoriasis, specifically COVID vaccination. This is an interesting question. The reason being that psoriasis worsens during COVID. So it is not recommended to stop any of the medications for psoriasis if a patient develops COVID. Of course, patients of psoriasis are not treated with steroids, but if the COVID needs steroids, go ahead and give it and manage the psoriasis later. That's number one. But the vaccination is a different ball game altogether, because there have been reports of the vaccination flaring up psoriasis patients. So, but unfortunately, since there is a pandemic which has already claimed 5 million lives in the world as of today, one should go ahead with the vaccination, and one should not hold it back just because the patient has psoriasis. There may be a flare-up. I agree with you on that. The flare-ups would be more likely with the mRNA vaccines, and yes, it can happen. There's another question from Dr. Suma Balan. As a pediatric rheumatologist, I have never needed so far to use biologics for my psoriatic arthritis patients, except for the ones who have axial disease. I totally agree with you, Dr. Suma, on that. I guess we use higher doses of methotrexate in rheumatology compared to dermatology. This is a very interesting point, which of course I have discussed more in dermatology forums, but this is a good forum to talk about it. The liver in rheumatologic diseases is different from the liver in dermatologic diseases. If you look at a pure rheumatological problem, let's say, for example, rheumatoid arthritis, the incidence of NASH is much lower than what we see in a psoriasis patient who is naive to any hepatotoxic drug in the past. So it is quite likely that you can use much higher doses. We see our rheumatologist friends using definitely higher doses of methotrexate compared to what dermatologists use. Dr. Ravi Shankar has asked about whether any of the biologics are indicated in patients less than 18 years. Answer is yes. Once we had Dr. Amy Paller join the IPC, she did a lot of work in Northwestern University, and she's a pediatric dermatologist. And adalimumab, that is Humira in the West, and etanercept have all been used 6 years of age and above, and there are some more undergoing trials.
Can I add also, Murli, that I was once in a forum with Alan Mentor, where he showed me pictures of pregnancy and biologics, and he says nothing happens in the outcome. Biologics are used in pregnancy psoriasis too.
Yes, they are used.
Ghosh, would you like to say something? Amit Ghosh?
Thank you. What I'll start by saying is, I think internal medicine's loss is dermatologist's gain. And that's what Dr. Muralidharan just demonstrated. With the use of big data and different abilities to do research, store data, look at it, all these different proteins, genes, and how they interplay is going to transform medicine. One is not very sure, though psoriasis is what we are focusing on. There are other diseases like HIV where you have an explosive case of psoriasis and others. So one doesn't know whether one is proceeding with a common pathway of all these changes going on. And then they manifest either as HIV or HIV with psoriasis or psoriasis and the other diseases. So it's a complete potpourri of thing which comes up. And once the body is riled up, and that's what Dr. Anand says, exercising decreases inflammation, and most of us either will never do it, or knowing well we cannot do it because of arthritis. But having said that, I was most amazed by Dr. Rajagopalan's empathy for patients with psoriasis, the intensity with which he spends time, which is so very rare, I must say, not only among dermatologists, but among all the physicians, that is probably transforming healthcare. So it's good to do research, good to do metabolics, but those are just identification of processes. But what you see in front of you, the patient, is very important, and that empathy needs to be, and has been highlighted by Dr. Murli. One of the things which I would say for marvelous medicine and for dermatology in particular, which I'm seeing in US, is using slides from Western population, white people. Because of the diversity, we would like to see more slides of Indians who are having psoriasis, people of color having psoriasis, because it tends to imply that there is importance of this disease only in particular race. And given the diversity talk, I would just request that the slides be more towards your own population, because these diseases are missed in Indian population and other, because there is a plaque here and plaque there, and that's thought about as a ringworm. White in a white population is easy to pick up. So that's just a side comment, but I'm seeing almost everybody changing their slides, pathology, dermatology, based on the racial inequity which has been judged. But apart from that, I comment Dr. Rajagopalan. I'm sure if you had to give this talk in another 2 years, it'll be a completely different talk. The slides would look the same, the skin lesions would look the same, but what you would talk about, therapeutics, pathophysiology, will change, and that's good progress. So I don't think at any point we can say we know everything about the disease. The more humble way of saying is that it's just like an iceberg underwater, and only the tip is there. And as we know more and more, the level of the water seems to be going down, and more of the tip is coming up. But regardless, I completely comment Dr. Anand. If you could all be like you, be running and doing things which you do, I tell you, 85–90% of our problems will not be there, period. That's probably the mantra which you preached, and thank you for that.
Bala, did you want to say something? I saw you turning on your camera, Bala.
Thank you, dear. Murli, that was a very wonderful one, yeah. But the cardiologists and dermatologists having in common connection with psoriasis, I think I take your point very well. All dermatologists must be a good internist. And next time, when I see my patients, I'll definitely look about psoriasis. It is a new perspective I learned from you. Thank you very much. A great talk, Murli. Congratulations. Thank you. Thank you, Vidya. Over to you.
Murli, there is a question about alternative systems like homeopathy and Ayurveda. Are there any results?
Yes,
He's going to blow up his top.
First of all, Dr. Vidya, I would just like to answer Dr. Amit Ghosh. Dr. Amit, I just, today's lecture, I totally take your point that my CV was not read out to you. I, in fact, run the Global Psoriasis Atlas for the Asia Pacific region. And we have the biggest collection of psoriasis patches in disease in skin of color. I didn't use those slides only because I'm not addressing a dermatology population, but we are addressing a diverse population. And the idea was not to teach psoriasis in the skin, but psoriasis in the internal organs. But I take your point. And thank you very much for the kind words you mentioned. And it's great to touch base with you again, Amit, from PGI days. Again, we are back here. Dr. Raj Kishore Bagdi is a very good friend of mine, and I hope you're doing well, sir, in Mumbai now. He has asked the question on alternative systems, homeopathy, Ayurveda, and the results. The simple answer to this is that I think we do not know enough to comment about it in a very, I would say, hard-hitting manner, one way or the other. The only thing that has been done is that Johns Hopkins has done a couple of trials on homeopathy and found that it was not better than placebos. But whether they did it exactly in psoriasis or not is something I have to check. But as far as Ayurveda is concerned, I have had patients who have improved with Ayurveda, and I have had patients who have not improved. We need to know why they did not improve. We also need to know why they improved. So the problem is that if you could have the same slide rule, which is going to measure the effect of Ayurveda or Unani or homeopathy and allopathy, and measure it in the same manner, in the proper way, I think we'll have a better answer to you, sir. As of now, whatever I say will be empirical.
Can I add on this?
Go right ahead, Anand. You are the moderator.
Yeah.
Go right ahead.
Yeah. See, one of the issues with alternate medicine is there's a total trust when a patient goes for alternate medicine, as opposed to a patient trusting the modern medicine. I wouldn't call it allopathy, let us call it modern medicine. So what happens in homeopathy is, way back in 1860, Murli will know it, Fowler's solution was tincture arsenicum, was a wonderful treatment for psoriasis. And very soon we realized that arsenic causes cancer. The patient's psoriasis went away, but then he comes back years later with squamous cell carcinoma all over his body, right? And Fowler's solution was formally there were advertisements peddling Fowler's solution as a wonder cure for psoriasis. Now in homeopathy, if you look at it, I had to go and read these things in homeopathy as to what they do. One of the treatment is, it's the tincture arsenicum is the treatment for psoriasis. As they say, like cures like. So arsenic produces psoriasis-like lesion. So give arsenic, psoriasis goes away. Fine. According to homeopathy, you dilute it so many times that there is no trace of the original and supposed to charge the water. That's their take on the water. But most of the homeopaths in India dish out their own homeopathy medicine. Remember that. All they need to do is tweak the mother tincture a little bit here and there, and the arsenic level goes up, right? And that's what happens to what happens. Yes, psoriasis does disappear. Some people come back and say, I am sometimes more worried when the patient's psoriasis clears with an alternate system of medicine. This is it may be a biased view, but I'm more worried when alternate system of medicine cures a disease without a validation of their potential or what is there. How is it? It's not validated. There is no study in validation. And more important, why is the person giving his own medicine rather than write something from the pharmacy? If it's homeopathy, let him buy from the pharmacy. But he usually dishes out this medicine at exorbitant price. I would rather give a biologic for that price and cure the psoriasis. That's my take on this.
Do you have anything to add, Murli, to that?
Well, I think it's a question of having a uniform validation, and the scientific principle is not different for different systems of medicine. It's the rationale of scientific thinking has to be same. So only then we can actually answer this.
I have three cases of squamous cell carcinoma arising out of homeopathy treatment given for psoriasis.
Yeah, I mean, anything with alternative medicine is bound to raise a lot of people's temperatures, depending on which side of the coin you fall on. But I think Murli's point is the most important one, that before we say anything, that is the only way we can come to a scientific conclusion and not an emotional one, is to have studies. We need to have studies done in the same way that modern medicine or modern treatments are evaluated. The same type of assessments, the same outcome measures, the same blinding, the same everything. The only question that I have, in theory, that's really wonderful, but in practice, it may not be that easy, because I would love to know which IRB is going to permit a study with arsenic being applied to a patient, knowing fully well that it could cause, some cancerous lesions eventually. So it may not be possible to do these studies. So, answers may never come. You just have to keep that in mind as well.
Yeah, your point is well taken, Ravi. If no one has any other questions, go right ahead.
I'm sorry, I'm extending. It's not a question. It's just that, I think it's one aspect that we did not discuss, but I did mention, is that psoriasis by itself is a disorder which can lead to lymphoma. So if the amount of immune dysregulation is severe enough, a patient of psoriasis may end up with lymphoma or even a non-melanoma skin cancer. So I would take psoriasis a lot more seriously. When Ravi was talking about cancer, I just thought I should bring this point up, because many a drug, even drugs like cyclosporin, have been blamed, saying that, this will produce a lymphoma, don't use this, but actually it is the primary disease. Inflammation after some time destroys immune surveillance. And when inflammation destroys immune surveillance, anything can happen.
Yeah, I was actually coming back to you, Murli. If no one had any questions, I thought you could give your closing comments.
My closing comment is, regarding psoriasis. When I started practice, I didn't think much of psoriasis. Today, I am fabulously humbled by psoriasis, because I know that there is so much. And if you really know your psoriasis well, in the, dermatologists used to keep harping, saying that if you know syphilis, you know medicine. I would say that if you know psoriasis, you know entire medicine. I think psoriasis is going to give us a lot of insights into the future, because not only have we found ways to give personalized targeted therapy and precision medicine, not only have we found methods to predict comorbid conditions which could alter the quality of life and probably even the duration of life. It has brought us back to Earth, and we realized that fitness, exercise, I've made a specific point to mention that psoriasis is an evolutionary gift to mankind. One needs to understand that if you look at psoriasis well and understand it well, your life can definitely improve. And there is so much work going on. This is the space to be in for a good dermatologist for the next few years. Inflammation in the skin is the space where you're going to see a lot of changes happening. And what we have now, we are realizing, even if it is concerned with the biolates, even there we are able to find that there is a difference in the effect of the different drugs in different people, which is why now the genomics is playing a big role. So what is right for me may not be right for you. So psoriasis has taught us that in very big, bold letters. So it's a very humbling experience to sit and practice psoriasis. It's not such an easy experience. It's a very humbling experience. It's an even more humbling experience to sit and discuss some of these aspects of psoriasis with a bunch of elite non-dermatologists like what happened today. That's a very, very humbling experience. So thank you so much for that.
Radhakrishna, what are your takeaways as a surgeon from this? Or do you want any clarification from Murli?
No, it's a pleasure listening to Murli. And as you say, I keep hearing everywhere that, in your class is one genius. I mean, it's nice to hear geniuses. And actually, I met up with one dermatologist in Shillong long ago, and I just made a mention. Oh, suddenly her face started glowing. He's my teacher. I mean, the respect which he had was such. Now, in spite of being in a corporate sector where there is not so much room for academics, I'm surprised how he is into some elite organizations across the world, because anybody in the corporate sector will be always bothered about how his money is filling his pockets rather than how academics are coming up. And this is something, is a very unique thing actually. I think wherever a diamond is recognized, whichever way it's presented. Now, as a layperson, I always understood this dermatology is something people harboring very grotesque, unsightly, non-photogenic lesions, and either itching or oozing, and at times contagious. This is what a general population. But then when I come to know that these are associated with some serious systemic illnesses, that's a lot more scary. And I think it's time for every physician and surgeon with this all to take to these things in much more seriously and try understand the plethora of diseases associated. And I think this is a little bit of an eye-opening, like, many of the marvelous medicine lectures are eye-opener that, and it's always nice to listen to a classmate of yours who's done so very well. Thank you so much, Murli, for this wonderful.
Thank you, RK.
Thank you, Murli, and thank you, Anand, for joining us. And thank you to all the audience who logged in and made this session so interactive. Murli may not have even got so many questions when he spoke to dermatologists, a wide variety of questions. And Ravi Shankar, thank you, Amit, always for participating and keeping the discussion going. Next week, we'll be taking a break, so we won't be having any session for Marvelous Medicine on the 13th of January. We'll be back on 20th of January with yet another episode of Marvelous Medicine. And with the Omicron raging, I request all of you to stay safe and a Happy New Year once again. Thank you all for joining. Good night and stay safe.
Thank you, Vidya. Bye-bye.
Thanks. Thank you, everyone.